All right, well, welcome back to episode 16 of Modern Prescription. My name is Dr. Deepak Dugar.
And I'm Dr. Jeff Toll, and it's my quinceanera, number 16.
Number 16. I know we need a princess uniform for you.
Yeah, that would be nice. You forgot to bring it.
I know. Today we're starting off with a little bit of a sad note. Last night, Chrissy Teigen, unfortunately, lost her child midway through her pregnancy. It sounded like she was in the middle of second trimester. Super sad.
So sad.
Yeah.
They're both great people.
Yep.
And really sad to see that.
Super sad.
I think this is it's so much more common. It's another thing out there that no one talks about. Is
miscarriages. Yeah.
Miscarriages, which are so common.
Yeah. Almost half of women have a miscarriage at some point in their lives during their reproductive years. Most of them don't make it this far, which is even sadder.
Yeah.
Most of them happen obviously in the first trimester.
But it does happen.
Yeah.
I have two really close people to me that have had
miscarriages
them and struggled and were sad after, and it's very sad.
Yeah, it's a sense of loss that I think only a woman can understand. We feel sad if it happened to us, but to our significant other. But gosh, can't even imagine.
I think a really important thing to think about if you have a loved one who ever loses a child, they have so much hormones during the pregnancy, and then it will take a whole swing when they lose the baby.
Right,
and so it can have emotional effects that you obviously it's emotional anyway, especially if you have other children that you love and you have a family that you're expecting a new child.
Right.
But even more so how the hormones affect that.
That's a great point, because if their behavioral patterns are off, accept it.
Yeah,
that's not the time to be like, why aren't you behaving?
Yeah.
Yeah. This is time to give them time to grieve.
So, and then on the note of fertility, we have a big fertility episode here.
Yeah, today's going to be a great episode.
Fertility.
Men's health, men's fertility with a urologist, with a U, not an N. So a urologist, and Dr. Justin Houman is here from Cedars, one of your colleagues.
Great
from
friend,
residency.
very smart guy, very good urologist, and
it's going to be a great episode.
Someone who will make you laugh and make you cry at the same time.
Definitely make you cry when he's talking about how he does a prostate exam and a needle biopsy if needed.
I think really important stuff here today.
Yeah, sexual dysfunction, erectile dysfunction, all types of stuff about sexual and men's health.
So buckle up.
Yeah, stay tuned. All right, and welcome back to episode 16. We are here with Dr. Justin Houman.
Urologist.
Welcome. Famed urologist.
We finally got a urologist.
A urologist, just so everyone understands, with a U, not a neurologist for the brain, a urologist
This
with a
is
U.
a person who decided to spend his life on penises and prostates. Is that accurate?
Kidneys, bladders, testicles.
Oh, there's other things in urology.
Well, and every male has one.
You're the pipe guy. You clean the pipes.
Yeah. Plumber.
Plumber. Wow. And you were at Cedars-Sinai.
That's right, for residency.
And you're now working here in Los Angeles.
Right.
And tell us, where do you work?
So I was at Cedars-Sinai for residency, went to UCLA for my fellowship, and now I'm at Tower Urology.
Urology.
In Los Angeles, right here in Beverly Hills.
That's a very prestigious big group.
That's right.
Wow.
So the two of us met during residency. So I was obviously internal medicine. He was urology. So we spent a lot of years in the hospital taking care of patients, and whenever I needed help with some urinary stuff, he was the guy to call.
That's great.
In and out of the hospital, right?
So now I understand the focus of your practice is really a lot of men's health, fertility stuff. So tell us a little bit about what you do.
Yeah. So obviously I'm a urologist. I'm trained as a urologist, so I do everything general urology.
And urologists are surgeons, just so everyone knows.
That's right.
I think a lot of people don't realize that urologists are surgeons.
Right. Exactly right. Some people, like in certain countries, they claim themselves as urologic surgeons. Here in the United States, we're urologists, but we do a lot of surgery. So for me, I do general urology, but my practice is I specialize in men's health. And what is men's health? Very few people know what men's health is. Really, the idea is, as much as women have an OB-GYN at the age of 20, and they carry them on, and they see them yearly for annual checkups, make sure from a health standpoint, wellness standpoint, they're doing well. Men don't really have that, right? The first time a guy goes into a doctor, it could be when they have some kind of issue. 50, 60 years old. And sometimes it's too late, right? They have chronic conditions that if they went to a doctor yearly or every couple of years when in their 20s or 30s, you wouldn't have that issue. So what I do is men's health, primarily male fertility, testosterone management, and erectile dysfunction or any type of sexual dysfunction. And And, that's the thing I'm trying to push. Men's health is very important because, fertility and erectile dysfunction truly are proxies for men's overall health. If you have issues with fertility, if you have issues with erectile dysfunction, a lot of times that's the first sign of having some kind of health issues.
I think that's definitely true. It's like the flashing red light that tells you that there's something else going on.
Exactly.
And I have found, a lot of times someone will have erectile dysfunction as the presenting symptom, and then you'll realize they have peripheral vascular disease, they have cardiovascular plaques on all the arteries everywhere, and that's why they don't have blood flow.
Exactly.
But they never saw a doctor because a lot of men don't. So I totally agree. I think, as far as men's health things go, you're sort of, in a way, if you don't see a urologist, you're sort of subject to how well your internist or primary care doctor knows that subject, which they may or may not. So I agree with you. I think when someone is really proactive about their health, they really should have a urologist that they're seeing. In your 30s, you may not need one, but by 40s, 50s, as the prostate starts getting larger.
Well, that's the question, though. Would you suggest someone in their 20s, 30s, just like women in their 20s start seeing OBGYN, would you suggest someone in their 20s and 30s start seeing a urologist for men's health kind of performance and checkups?
Well, that's a good question. So, a urologist deals with urologic organs, right? So as important as those are for overall men's health, there's more to the body than just our organs. So going to an internal medicine doctor early on, being proactive in that sense is good. But when it comes to the other issues that are primarily urologic, that's when a lot of guys they're not active in addressing those issues. So if you are having it, it's very common in your late 20s, early 30s, guys will have some form of erectile dysfunction, especially in Los Angeles, especially with, as pornography becomes more and more common. It's a real issue, right? It's a real issue for a lot
So
of
you
guys.
feel like pornography is leading to more erectile dysfunction?
Without question.
What do you mean by that?
Absolutely. I mean, I think guys in general, you get desensitized to a certain extent.
So they're overstimulated, you're meaning by the pornography, so then they can't perform in their real life?
Right.
Gotcha.
Right. So the expectations, reality versus expectations mentally is off.
Interesting.
And because of that, sometimes, the way they perceive themselves, their penises, how they perform sexually versus what they see on TV or when they see in these movies, it doesn't match up. And then a little bit of stress and that anxiety, it's a downward spiral.
Is there a connection for you necessarily between like the sex drive and then ultimately the erection? How are those linked, or are they typically?
Yeah, it's a good question. So, there's so many things that go into libido and erectile dysfunction, like two Venn diagrams, if you will. And there is an overlap, right? There's definitely an overlap. The way I like to think about it is if you have bad libido and you have erectile dysfunction, you could think that testosterone is mediating that, right? That's a testosterone source. But sometimes guys will come in, like you talked about, they purely have peripheral vascular disease. Their libido is strong. They're good, right? They're ready to go at it whenever they want. But when it comes,
but that would be older patients. Usually.
Older patients, right?
Smokers.
Exactly. Diabetics, hypertensive patients who are on hypertensive medications.
Right.
Those patients, there are two separate.
Sure.
And with those patients, are those patients that you would prescribe medication for?
Yeah.
Okay.
Yeah. I think Jeff will tell you, anybody could really start guys off with the PD5 inhibitors, the Viagras, the Cialises that we know about, right? And that works for 70 to 80% of men. It really does. And most guys will actually be able to, there's no desensitization to these medications just because of the mechanism of it. But there's tons of options for those 20 to 30% of guys who don't have responses to these medications.
What else?
Oh yeah, there's a ton. You could get more invasive, right? I always tell people, you will have an erection. I promise you'll have an erection some way, somehow. Just depends on how aggressive you want to be, how invasive you want to be. There's a ton of, there's gels, there's injections directly in the penis, there's shockwave therapy. This is a new one where that's more of a regenerative form, regenerates the penile tissue.
Wow. So shockwave therapy is like radio frequency, or is this just literally impulse waves?
Yeah, it's mechanical shocks to the penis over a course of about 6
And it's trying to remodel the muscular anatomy?
Yeah, the smooth muscle regenerates.
Smooth muscle regeneration.
And then, you get vascular genesis. What's an erection? It's more blood flow. So you get more blood vessels, you get more, you get stronger erections.
Wow. They've created a device like this for women for the pelvic floor. Asmela, it's called.
The Mona Lisa?
Yeah. And there's different ones. That's a different one. But Asmela and Mona Lisa. But you sit on it and it vibrates and it has the mechanical contractions so that it helps
strengthen. So it's basically
strengthen.
giving you Kegel exercises with
kind of the concept.
Yeah.
Exactly. Just to get the muscle strengthened. So that's the concept of the shockwave therapy you're talking about.
Similar.
Okay.
Yeah, similar. But
and then what did you say? The injections? That sounds very painful. Explain that a little bit more.
Yeah. So, A lot of guys are averse to it, as you can imagine, because you're injecting a needle into your penis. It's like an insulin syringe. But yeah.
Cringe.
Yeah, cringe.
Well, once the taboo's broken, they do okay with it. Right before intercourse, you inject yourself.
Whoa. So this is at home self-injections.
Yeah.
Well, just like insulin.
Just like insulin.
Wow.
Yeah.
And what are they injecting?
So there's different combinations. Most common thing is trimix, which is a combination of 3 different erectogenic agents. And there's different concentrations, different volumes. But
are these all focused on blood flow? Just getting more blood flow? Okay.
Exactly.
Wow. Okay.
Glad I don't need that.
Do you prescribe those, Jeff?
So I don't prescribe. So my typical practice so in terms of prostate enlargement and stuff, there's a couple different drugs that we feel comfortable as internists prescribing, things like Flomax, things that sort of open things up a little bit, help you empty your bladder out. When people have more enlargement, we can think of, alpha blocker.
Prostate
enlargement.
Yeah.
Most internists feel pretty comfortable with the basic Viagra, Cialis. I think a lot of times it's nice for us to be involved in that decision if there's a real blood flow problem, because we want to make sure it's safe. We want to make sure it doesn't mix with their other antihypertensive medications, heart medications. So sometimes it's helpful to have the internist involved in those, especially in elderly people.
Smart.
But once it gets more complicated than that, that's when we have our urologist to lean on.
Dr. Houman.
So here's a question for you. So there's a lot of controversy regarding prostate exams, digital rectal exams. So this is one of the main reasons why men don't want to go to the doctor in the first place, I have found, is they're happy to get their blood drawn. They don't want the doctor to put their finger in their butt and touch their prostate. And that's actually the reason why they don't go to the doctor. So, in my mind, there's some controversy here because number one, the PSA test now is very, very sensitive. And number two is a lot of times, even when we see a rise in the PSA or feel a nodule, that's something that we're going to watch and not necessarily do something about. We're going to get imaging and follow up on. So my take is I never want to scare a guy away from doing their annual visit to check their cholesterol, their sugars, by them worried they need to get a digital. So I think I'm pretty lax on passing on that because I think the PSA is very helpful, especially in younger men who are unlikely to have prostate cancer. I know the urological societies want us all to do rectal exams. And to me, the controversy is, do the urologists want us to find more early cancer and precancer so they have more consults and more visits to see? Or do they really feel that there's some saving of lives and some early detection that we're going to gain by doing the exams?
Well, let's start with the prostate cancer. What is it a dangerous one? Is it not a dangerous one?
Prostate cancer in general. Prostate cancer, yeah. So it's a cause of death, one of the leading causes of male death, right, in America. We're getting much, much better at it. Number one, from a PSA standpoint, trending the PSAs. Digital rectal exams help as well. And then, like you said, the imaging. There's these MRIs of the prostate, which are highly, highly sensitive.
Right.
That gives us a good look inside the prostate, and you're able to see cancerous nodules.
When would you suggest doing an MRI? Would that be only if you see something on the digital, feel something on the digital exam?
Or a rise in the PSA.
Or a rise in the PSA,
okay.
Exactly.
So how often do you digitally feel something that has no rise in the PSA? Like how often is the exam itself the key to finding something that could be potentially life-threatening?
Yes. So I would say in the single digits, right, in terms of percentages. But it's something, right? It's something there. I'm with you in the idea that PSA it's good. It's good. It's not perfect by any means. And the combination of PSA plus MRI is great. But most guys, at least for us, right, when they come to a urologist, the expectation is that they're going to get a rectal exam, right? A lot of them complain depending on how big your finger is, right? Some of these urologists, they have bigger. Yeah,
that's funny.
Yeah. So it depends, right? It depends. So for us, it doesn't. The bar is set very low. They're willing to get it done. But I get what you're saying from an internist standpoint.
Well, I think men tend to not want to go to the doctor, and so that's why I think your point so well taken about men's health, encouraging people to go to the doctor. It's so important. And almost every guy who's under, I would say 50, who goes to the doctor will say, oh, my wife's or my girlfriend's making me come. My wife said since we had kids that my son's 5, I got to start going to the doctor or whatever. They rarely want to go. I think that's one of the main potentially a contributor to why they don't go.
It is. It is. I agree. But I will say this. The reason why guys would go into the doctor, if they have erectile dysfunction, right?
Yes, that is a reason.
Yeah, they're going to go to the doctor.
That's a real reason.
Right? And the thing is, like, people think erectile dysfunction is such a taboo thing, right? It's like, it's so rare. Man, it's so common. It's so common.
What percentage do you think of males have erectile dysfunction?
Yeah. I mean, generally.
Some form of it.
So you see at 40% of guys do. At age 40, 40%.
At age 40, 40% of the guys have erectile dysfunction. At age 50,
about 50%.
Wow.
And it goes up 60, 60. Yeah.
So what qualifies, does occasionally losing your erection count as erectile dysfunction? Does only lasting a few minutes? What is like qualifying as worthy of being treated or abnormal?
It's, it's even the mildest form is considered erectile dysfunction. At least that number I'm giving you, that 40%, even the mildest form. Is it to the point where they're unable to have pleasurable penetrative intercourse? Probably not. But if you have it at 40, right? The idea is if you have it at 40, rarely does it get better, right? Or if ever.
Good point.
Either plateaus, right? It stays there, or it slowly gets worse, right? So why not nip it in the bud early? Why not evaluate it and get it seen early, and then treatments? See your internist. They'll give you some medication.
Well, if you take Cialis and Viagra at a younger age, let's say you're a 40-year-old or 50-year-old, are you committed to that now the rest of your life? If there's no other underlying medical problems.
Right, exactly. Unlikely, right? Unlikely. So sometimes you'll have a college student who will come in, right? Had a whiskey dick, basically.
Yes.
Had a bad sexual encounter.
That's a medical term.
Yeah. and then the next time they're trying to have sex, they they think about it. They think about that previous shitty encounter, and that stress, any type of sympathetic response kills the
anxiety that they're driving from their previous experience.
Exactly.
Wow.
So what I was gonna say, so I think one idea that I think you and I share in terms of proactive health and men's health is that the old way of looking at medicine was always like, I have a major problem, so I come into a doctor to fix it. So someone comes in because they really cannot get an erection at all, and that's when they finally go to the doctor to see it. And you see it, and I see more as like, we're trying to make people's lives great, maximize, like perform well, to perform to the way you want to. And as long as the medications are safe to use and are not causing side effects or causing other medical problems, it's what they're coming to us is for help to perform. And so, and we've talked in the past about this before, is, whether we're talking about cosmetics, whether we're talking about anything, the old way to look at medicine was this so stagnant. Like, I have a problem, I go to the doctor, they fix the problem. It was never, why don't we give people full lives, happy, make them feel better about themselves, look better, feel better. And I think that's really important, and people shouldn't be embarrassed. They should, it should be like,
100%.
Like people, if they have a fancy car, they want to put in the best gas. If people want to buy nice clothes, people want to vacation at a nice place, and they don't feel that that's anything wrong. But then with their own body, then they,
I think there's a big taboo around sexual health, like you said. Like, erectile dysfunction is just poo-pooed on. It's like, oh, dude, you can't tell anyone about that if you have that.
Right.
And so I think that it's so sad, because sex is without a doubt one of the most pleasurable parts of our lives. Like, every human on this earth, if you're of age, and or depending on your religion, married, it's the most pleasurable part of our lives, right? It's the most pleasurable thing that we can experience. And yet we give it absolute zero time in terms of discussing how to improve it, how to maximize it. We maximize our bodies, our minds. We go to Tony Robbins courses. We go to workouts. We listen to Katie Austin's HIIT workouts on Instagram, but we won't do anything about sexual performance and health and increasing it. So I think it's a great way to start the conversation just by listening to this podcast right now and understanding that sexual health is something that you have to think about for the rest of your lives.
And it's not, everyone ages, right? Everyone ages. And this is not like the things that we're offering. Jeff could tell you. It's not like, these aren't crazy things that we're offering.
Right.
Just optimizing your health, improving your quality of life, your sexual quality of life, your overall quality of life.
And the thing is that leads to so much other, you'll be healthier. If you're having sex more, you're going to be healthier in a lot of ways.
Right.
You're going to be less anxious, less depressed.
More cardiovascular.
Your mood is better, and you're using cardiovascular. A lot of relationships and marriages are better when there's more sex, and that leads to your life in general being better.
Absolutely.
Even your work could be better, sleep better. So
I wanted to get to, sorry to interrupt, I wanted to get to types of penises, like you were talking about earlier, and who would be a candidate for an implant, and what is what do you call it? It's like the Italian beer.
The Peronis,
Peyronie.
pierogies.
So what is that?
So, we're talking about the options for erectile dysfunction, right?
Okay.
We start low with oral therapies, then you could advance. And as I said, we promised you an erection, but you could have an erection no matter, some way, somehow. It depends on how aggressive you want to be. The most aggressive way is surgery, right? It's called an inflatable penile prosthesis. And
Whoa. Inflatable penile prosthesis.
It's not the Swedish penis enlarger.
Yeah. I've seen that on Seinfeld.
No, it's Austin Powers.
Oh, yeah, that's right. This is not a pool floaty. So what is this?
It's not a pool. This is, it's a 3-piece prosthetic device. You have a reservoir that sits in your lower belly, your lower abdomen. You have a pump that sits in your scrotum. It's all internalized. And you have 2 cylinders in the penis. And what you do is whenever you want to have an erection, you just pump it up. The fluid flows from the reservoir into the penis. And you're able to have a strong erection. And then when you're done, there's a release valve.
I wish podcasts were on video so you could see him visually pretending to pump his scrotum to see this thing pump up. That's incredible.
Remember the days
in the 90s? Shoes, the old shoes you used to pump up?
Remember the Nike shoes used to pump it up?
Yeah.
Reeboks,
yeah.
Or Reeboks.
Classic Reeboks.
Just like that.
Yeah, and there's the myth that if you over pump it, you'll blow your shoe up.
I think Reebok went out of business because they said, is Reebok still in business? I think they are, but they should go back to the
They
pump.
need Kanye West, clearly.
What? I thought Kanye
saves every line,
isn't he?
No, I'm saying that they need, they need something like that.
They need Kanye.
They need somebody. But so back to the Reebok inflating. The theme was you could blow up your shoe. Can you blow up your penis?
No, you can't break it.
You can't break.
You can't break it.
Well, I mean, I don't want to say you can never break it, but it's very difficult to break it.
Wow.
Oh, wow.
Very difficult
Incredible.
to break it.
So I know another area where you help people is with fertility. So, I think a lot of couples, when they're trying to get pregnant, and even couples who aren't really trying, but they're not trying not to, sort of. Mm-hmm. And then they realize, a couple, years gone by, 2 years has gone by where we aren't really not trying anymore, but we haven't gotten pregnant.
Yeah.
When should a couple seek, advice? When should people start to get tested to see if there's a problem? How long if you are trying, is long enough that we say, there may be a problem here that we have to investigate?
Yeah. It's a good question. I'd say, so generally I tell people 6 months, right? If you've been trying with your partner actively for 6 months and still haven't achieved it, any type of natural, spontaneous pregnancy, at that point it's worth to get evaluated. And it's not just the woman or just the guy, both of you. It's really 50-50, right? 50% of the time it's the guy's fault, 50% of the time.
50% of the time is the guy's fault.
I don't want to say the guy's fault, but 50% of the time the guy's it's his issue, right?
Amazing.
I've always
Great
been
to
told
hear
it's
that.
always the guy's fault.
I mean, that's probably true.
Your wife probably says that.
Yeah, everything's my fault. But I take it with the greatest
But in
fault.
any case, so let's say we're trying to figure out if it's the guy's fault. So what do you do? What do we do?
Yeah, so it's something very as simple as a semen analysis, right? So that's the way you objectively measure someone's semen parameters and see, there's different things. You see the counts, the motility, how fast they're moving, what they look like, the morphology, the total volume in terms of how much you're ejaculating, and then the total sperm count. And there's a bunch of other advanced tests, but that's the most basic initial test.
Which one of those is usually a higher culprit?
Depending on what the pathology is, right? Depending what's causing it. Sometimes it's the varicocele that's causing it. Sometimes it's genetics that's causing it. Sometimes it's their lifestyle, right? Whether they're drinking alcohol, not exercising, poor diet, those types of things. But across the board, there's no one that you could say this. If you improve this one, you're more likely to achieve pregnancy.
And what things would prevent you from having ideal sperm morphologies? Like you were saying, lifestyle. What does that mean?
Yeah. So obviously, drugs, alcohol, right? Those types of things could.
That influences it.
Absolutely.
So if you're drinking and you are doing drugs in general, then your chances of having kids is lower?
It could, depending on where your baseline is, right? And depending on how often you're using it.
That's the rock stars.
Yeah.
They never have kids, I guess.
Not that they know of.
Wow, interesting.
So
what is semen analysis? Explain that. What is that process?
So semen analysis is you go either to a lab or our office, wherever, and
do you bring something from home or do you perform it there?
So one of the two,
Okay,
right? If you do it at home,
matter.
some guys are more comfortable doing it at home.
Yeah.
We recommend you should bring it within an hour or 2 hours.
Okay, got it. So it's still able to be tested.
Exactly.
Fresh, yeah.
It's still fresh.
Sample, yeah.
Most guys will do it in the office.
Wow.
Yeah.
Interesting.
That's why I don't go into your exam rooms.
It's in the bathroom.
So
this isn't, it's funny because it's three guys and it's still an uncomfortable topic. So I understand
Very
what the whole,
comfortable.
we're all doctors. So it's like, I could see how the general world just looks at this and goes, never mind, let's not talk about it.
So, how about this one? So men, it seems like actually can have children much older ages than women are. So walk us through that. When is it typical that men's sperm is still like safe to have children? When is there any time where it's more likely you're going to have problems with like the chromosomes or problems with the children?
way that we
because we know women, we say after 35,
the
more
high
likely to
risk
have
pregnancy.
more likely to have Down syndrome, more likely to have problems. Is that rule applied to men, or do we get off scot-free on this one?
No, we're responsible too. It's I guess with women, you're right. I think they say is it 30,
35 is
for
like
Down
the
syndrome?
high paternal age.
Yeah. It's not, for men, obviously, it's the older you get, but typically above 40, the quality of your sperm is not the same, right? It's not the same.
So would that genetically lead to a possible complication?
Potentially, right?
Oh, wow.
Again, but it always takes two to tango. So it depends on what your wife is bringing or your partner's bringing into the mix as well. So it's tough to say, if you're 42 as a man, what you're more likely going to have is a genetic issue. It's the wife's going to be there too. So it depends.
And if you're trying to get pregnant, and a lot of men take a drug called Propecia, which helps them with hair growth, which was secondarily found because it was initially a prostate medication that ended up having people grow hair, right?
Right.
Is that decrease their ability to have a child, or what is the effects of that on the prostate?
Yeah, that's a great question, actually. It does. It does have issues with semen parameters.
Wow.
It does. But you could just come off of it, right? You come off of it. We test your semen quality, we see your semen parameters, see what it looks like. And then if you achieve pregnancy or when you achieve pregnancy, you go back on it.
Ah, interesting. So, and what does Propecia do to the prostate?
So Propecia decreases, Propecia blocks the conversion of testosterone to this DHT hormone that allows for prostate growth. So it decreases the growth of the prostate, the vascularity, the size.
And so if you stop Propecia, will your prostate then grow sometimes?
Yeah, exactly.
Cool. So, because I have a lot of patients, like older patients with hair loss, who take Propecia, and sometimes they'll stop taking it for whatever reason. And if they're in their 50s, 60s, 70s, and they've noticed sometimes that their prostate got bigger when they stopped taking it. Because they've been taking it for like 10 years plus, and then all of a sudden they stopped. So it's interesting that it can control the size of the prostate in a way. Would you recommend people stay on drugs like Propecia just to maintain their prostate, or no?
But the thing is,
Depends.
it has side effects, right? It has a lot of sexual side effects.
So I've noticed my younger patients, let's say 30 to 50, who use Propecia for their hair, start like I'll tell them before they start it that they may have a side effect of less drive, and maybe erections that are affected. And then they'll forget that, and 3 months later be like, "Oh my God, my hair is amazing! I'm so happy." And then
that helps drive.
And then like 6 months later, they'll be like, "I don't know what's wrong with me. My sex drive's off." So I think all drugs are double-edged swords. You gain something, you lose something, and we always have to remember that and be aware of that. But some people who do have enlarged prostates, we use it actually intentionally for the prostate reduction in size because it'll help you empty. So I'm sure you can tell us a little bit better, but the drugs like Flomax, these are dilators. They help you empty, but the drugs like empty your bladder, pee everything out. So for those of you who wake up 3-4 times in a night and you're wondering why you're waking up so many times, a lot of times the problem is you're not emptying your bladder. So 2 hours goes by and you feel like you got to go again. And that's true because you haven't emptied all the way. So the drugs like finasteride shrink your prostate over time, and they allow you to actually empty better even without potentially the Flomax down the road, but it takes a while to work. So that's something where you're not going to see the effect of it for a few months probably at least, right?
Exactly. Also Cialis, there's we use that. Cialis is great because you kill two birds with one stone. It actually helps you urinate as well. It helps open up that prostate. So it treats assists your erectile dysfunction, but also helps you urinate. So
Cialis,
and that's typically a lower dose, right?
Yeah,
of the
lower
Cialis.
dose.
And you prefer Cialis generally over Viagra? Just
absolutely.
Okay, because of its second benefit.
Well, even for young guys, I mean, it lasts for 24 hours, right? The thing about Viagra is you have to have it on an empty stomach.
Oh,
Yeah. So if you have, if you're drinking or having fatty foods, or you can't do that, right? You can't be on Viagra, but or it decreases the efficacy. Cialis, though, you're fine.
And what's the difference in how long they last or how effective they are?
Yeah. It all depends on the patient too, but Viagra generally, I mean, it lasts a lot shorter. It's shorter, a faster peak, faster fall. Cialis, they call it the weekend pill. So you could, some people would take it on a Friday night and they're able to last until Sunday, right?
Wow, interesting.
Yeah.
Interesting. And these are all prescription medications.
Prescription medications.
Yeah. And what about, like, you go to the gas station and you see over the counter, those get hard pills. And those are all made up?
Yeah, I mean, that's the stuff Lamar Odom did, right?
Is it?
Yeah, he did some of that stuff.
Oh, man.
Yeah.
Poor guy. Go Lakers.
Go Lakers. 1-0 right now. So those are scams. Stay away from that stuff.
Yeah, I mean, there's maybe placebo effect is something that you have to, placebo effect works. So I'm sure it works in some guys, but
I love the placebo effect.
Yeah, it works.
Big placebo guy.
Me too.
So the placebo effect works about 20% of the time, and so, but with no side effects, unless someone is really paranoid, then they can have side effects from placebo,
right?
Which is their anxiety. Their anxiety is the side effect.
Yeah. Then you have to spill the beans.
Yeah, you have to tell them it's placebo. I think, they should actually have medications where the doctors know it's placebo, but the patients don't.
That'd be great.
Give them a sugar pill.
Yeah.
Yeah, that'd be great. But then also they gain weight because of all the sugar in the pill.
Diabetes.
So what else about sexual dysfunction should people know about? I mean, so it sounds like not getting pregnant could be the guy's fault. Not getting an erection could be a medical issue / an anxiety issue. Seeing a urologist earlier than later is smart, based on your primary physician. So your primary care physician should be your first stop, and should there be issues that they deem needed for a urologist, you'll be sent there soon. What else in the sexual health world would you suggest people do?
Testosterone. Testosterone's a big one as well, right? You do treat
Yeah, so
testosterone?
I not most internists I don't think really look into it. I think checking hormones is a really important part of people's health. So there's some doctors who are like hormone doctors or endocrinologists, which I'm not. But I definitely am checking, and you tell me if this is right, I'm checking basically people's free and total testosterone, their sex hormone binding globulin, DHEA, and I'm sort of getting a sense of low, high based on their age. There are problems with being on testosterone if you don't really need to be,
Yeah, and we talked a lot about that.
Some cardiovascular issues, some sugar, kind of insulin resistance stuff potentially over time. But when people are low, their life is very affected, incredibly affected.
Exactly.
And so there's really no side effect or harm to get someone to the right level. There's side effect or harm when someone has a normal level and you go way above it with giving them the medication when they don't need it.
Like athletes sometimes
But
being
if
super therapeutic.
But just like when someone is hypothyroid and we replace their thyroid hormone, if someone is low testosterone and you're replacing it to a reasonable level, then you can completely change someone's life. People can present depressed, present fatigue, and then ultimately you find out it's actually testosterone that's the problem.
And that can be affecting their sex drive as well, and erectile dysfunction as well.
Yeah, I 100% agree with what Jeff is saying on that. Testosterone is super important. Guys, your levels of testosterone are always going to go down as you age, right? Naturally. But there's nothing wrong. And there's data to support this, that if you get a guy from like hypogonadal, low testosterone to a normal testosterone range, first of all, your overall survival is longer. Your risk of cardiovascular mortality, your risk of cardiovascular events, all these things are just decreased. Testosterone's good. You need testosterone as a guy, right? You're not shooting them up to the bodybuilder levels, but just getting them right where they should be.
Exactly.
Yeah.
Right. Totally.
And the thing about testosterone, when I don't know if you've encountered this, but that they give a number, it's less than 300, less than 350, whatever. Different societies.
Total testosterone.
Yeah. Different societies have different numbers, but the thing the way I see it is, my testosterone requirement is different than yours and different than yours, right? Everyone has a different testosterone requirement. So the number gives you some sense, but it's the symptoms too, right? You got to treat the symptoms.
Right.
And you look at a guy who comes in and he's, jacked and juicy, he's a big guy. His testosterone requirement's a lot higher than ours, right?
Yeah.
I feel the same way. I feel the same way about thyroid and some of the other hormones too. I'll have people who technically are hyper on their medication, but they still feel a little tired. And if you actually make them a little more hyper, they feel normal. And their weight is staying fine, and they're not having anxiety. They're sleeping fine. There's no issue with it, and they feel better there. And this is part of my, general premise that the old way of thinking in terms of we're treating a problem and we're going to get you right in the normal level is not necessarily what's in the best interest of the person in front of you, especially if, for some people, I mentioned this before, like hormone replacement for women too, which can have real consequences like cancer risk.
Mm-hmm.
If those people, if a woman wants, estrogen or progesterone after menopause, and they understand there may be some risk involved, but they feel so much better, who am I or who is their endocrinologist to decide what is a life that makes more sense?
Right, which risk they're willing to take.
Yeah, because if you're your quality of life is that much better, and you're gonna be willing to take a 1 to 3% increased risk of something, that's your prerogative. It's not. I'm not you. I'm supposed to advise you on here are the potential risks and benefits, and then we're working together to decide what's the best route for you.
Right. Let me ask you: when you offer testosterone, are they fearful of it?
Definitely. I think it's something they're not well educated about. I actually don't really prescribe it that often. Typically, I'll pass it off to, sometimes it's endocrinology, sometimes it's urology. But I am screening for it. I think as an internist in all the different ways. So I'm screening for cardiovascular disease. So if I do a calcium scan, let's say, and someone has a whole lot of plaque on their artery, they need a cardiologist involved. And I'm screening for all of these different things, including their testosterone.
Yeah.
I'm not necessarily treating all of them always, but my job is to kind of diagnose things early so that they're in the right hands of the specialist to treat these things.
Exactly.
Yeah.
Exactly. The one thing I will say about testosterone, I don't know if you guys remember this from medical school maybe, they used to say testosterone causes strokes, heart attacks, those types of things. There was like one study that had this back in the day. And ever since then, they've done a bunch of scientific studies on this. And it's all been disproven. So it's like the fear of testosterone, it's not, it's a good thing. It is. Guys need it.
Yeah.
I like it.
I'm a big believer in it.
At therapeutic levels, not
therapeutic,
not super therapeutic.
Yeah.
And so I wanted to talk lastly about the cosmetics of the penis, because we talked earlier about Peyronie's. So explain, what is that? And also I wanted to ask you, because there are some people in LA and New York who are starting to do cosmetic injections, like fillers, into the penis to give more girth and to give it a better look. I don't recommend this.
That's real?
Just anyone's listening? Yeah.
So when you're hard, they give you Botox? Wouldn't that keep you soft?
No, so no Botox. They're using fillers to make it bigger, to give it more girth.
Gotcha.
This is obviously mostly in the gay population. There's certain doctors who perform a lot of procedures for them. And so there's different procedures that they do. There's a dermatologist in LA who does a lot of this, including he'll do butthole tightening with radio frequency lasers to make the butthole tighter for male pleasure when they're having their sexual intercourse as males. But in terms of a penis filler, would you recommend anyone ever do something like that?
When it comes to the penis filler, I mean, so we don't do it. Right? Yeah. We don't do it. I think it's more of a cosmetic.
You don't do it, even though you're a urologist who's trained in this anatomy better than a dermatologist.
Yeah. I mean, the only time I've been involved with penis fillers is we've had to take them out, right?
Oh my gosh.
And I can't necessarily speak on if it happens all the time, but what happens is sometimes it gets, the filler at the beginning is probably spread throughout, the subcutaneous fat, but eventually it starts clumping up and you have these like nodules all around your penis. So that smooth contour of the penis is gone. It starts to look,
that just sounds painful.
Don't sign me up for this.
Don't sign me up either.
I'll pass.
Agreed. And then what is Peyronie's, and what do you guys do for cosmetic deformities of the penis?
Yeah, so Peyronie's disease, there's a big push. There's a lot of advertisements out there now because it's common, right? 1 in 10 guys has some form of Peyronie's. It's just curvature of the penis.
1 in 10?
1 in 10. 1 in 10.
Wow.
It's genetic. Sometimes it's genetic. Sometimes it's trauma. So a guy who has a fractured penis, for example, he may develop Peyronie's years later.
What does a fractured penis mean? Isn't the penis all muscle?
Yeah. Yeah. So I used to think that too, actually. But what it is just think of the penis as like a balloon, right? It fills up when it gets engorged. The balloon's filling. If that outer layer pops from too much trauma. Typically, the way we say it is like when someone's if someone's riding on you, reverse cowgirl, it potentially could crack it.
Medical term.
Yeah. It potentially crack it, and that scar, that scarred area could become a Peyronie's plaque.
So the scar itself is what creates the curvature.
The curve.
And how do you guys treat that?
There's the most basic option is something called Xiaflex. It's collagenase injections directly into it. What the scar is collagen. This is collagenase, the enzyme that breaks it up.
To break up the scar. Got it.
What's interesting is it sounds like when you have trauma to your nose, when you can have similar,
like very similar. Crooked nose.
Crooked nose
or crooked penis. Yeah.
So they're using collagenase actually for cellulite. Yeah.
So superficial injections to try to break up the scar tissue.
Exactly.
Very cool. And then what do you do beyond that if the collagenase doesn't work?
Surgical options.
Okay.
Right.
What do you do surgically?
So there's depending on what the plaque looks like, but the simplest one is something called application, where you go in there and you suture the other side of the penis and you bend it. You bend it into a straighter penis, but that shortens it, right? That significantly shortens your penis.
That you want to avoid.
Yeah. So this is purely cosmetic too at this point, right?
This is purely cosmetic.
Yeah. And then what is the more intense options?
Depending, again, if it's calcified, the plaque is not collagen anymore. If it's calcified, at that point, you have to go in there, surgically remove that plaque, and then you put a graft on it.
Whoa. Hardcore.
Yeah.
Hardcore.
Yeah.
So cosmetics, is there people who specialize in that?
There's not so much here in Los Angeles. I think there's some people who do plastics and urology combined. But there's a guy in Atlanta, I believe, who specializes in cosmetic urology.
Wow, very interesting. Very interesting. There's something for everything.
That's
the craziest part of medicine.
If you want something, you'll get it.
Yeah. I'm looking for it makes sense though that there would be plastics for urology.
Yeah, it makes sense. I mean,
I get it.
I mean, again, it's the most vital organ on our bodies as males, and females feel the same way. I mean, female vaginal rejuvenation procedures are very common.
Yeah,
like huge.
Right.
So vaginoplasties are extremely common just to make it look prettier, look tighter, and also function and form, because sometimes it does cause a lot of irritating chafing when you have oversized vulva. It's painful sometimes for a lot of women. They can't ride a bike. They can't do basic things. So there's a form and function to it beyond just the cosmetics. But I think males do not ever talk about this, think about this.
We don't like to talk about it.
No, it's just totally taboo. I mean, even like the basics of when you're, having a kid
we
one day.
We don't talk about our own. We have locker room talk where you pretend you make fun of the other guys.
Yeah, but you don't actually
see it
No, you don't actually talk about it. But even like basic things like circumcision. Who does a circumcision for babies is like the neonatologist. The rabbi does it?
The moil.
Oh my gosh. You're Jewish, so you know a lot about this.
The moil does it.
Okay, interesting.
Very important.
Very important part of your life.
I think both urologists and some OBGYNs do.
That's right.
Oh, so
probably more OBGYNs.
So urologists will do, like, for an adult, let's say there's an adult who
I thought you meant a baby.
No, a baby, of course.
I had mine as a baby.
Just to clarify. You've been Jewish since birth.
Yes, my moil did his thing when I did before.
If someone converts to Judaism later, then they have to go get it done?
That's a very interesting question.
I don't think so.
We don't accept a lot of converts, first of all.
You guys are
but
private
when
society.
we do they get a circumcision? I don't know.
I don't think so.
I've never thought about that. That's interesting.
That's a great question.
I need to find out. On this episode of Ask Your Rabbi.
Yeah.
I don't know.
Maybe we'll have a rabbi on next episode. It'll be a very different discourse than this one.
I wonder.
So it's amazing how many, it's funny because we don't think about how many things a urologist does.
I know.
We've left out like two of the main organs, which are the kidney
and the bladder,
kidney stones, like all these things that you guys do. Because I think, my cousin's actually a urologist also. He lives in Ohio.
Oh, nice.
And
Shout
he picked urology because he likes to do big surgeries with the robots and the Da Vinci robot and stuff. And they have all this cool equipment that you guys use.
Yeah, urologists and ENT residents were always really tight in my hospital because it's kind of like those are like the two like nerdy surgical fields.
What the hell?
Where ENTs and urologists. They're like the subspecialists. So like we're kind of out of the pocket of the general surgeons. So like the general surgery residents kind of were like, you guys don't know anything about the real surgery, trauma surgery, and we were happy to not know anything about it.
Right.
But what about kidney stones? That's a great one you brought up. When do people usually get those, and what causes them? And
so it's, usually in the summertime, dehydration is the number one thing that causes kidney stones. So like we just went through even now, like with this heat wave going on, I'm sure in a couple of weeks we may have like a surge of kidney stones. Pretty benign. You have significant pain with it, obviously, but the treatments are great. Something called laser lithotripsy. We put a small camera into the bladder, up into the ureter, blast a stone, and take it out
With the laser?
with a laser.
Wow, laser.
Sharks with
So
lasers.
yeah, sharks
Yeah, it's like
with
playing.
laser.
It's like playing asteroids. Remember that game?
Wow,
That's what it is.
Really? And then you break it up into smaller chunks, and then it comes out.
It all sprinkles out.
Wow, that's so cool.
Yeah.
So what else? I got so many internist questions for you. Like,
Yeah.
when do we do this? So, okay, here's a super common one. So you go to your annual checkup and they take your UA, and we see microscopic blood in the
UA is a urine
and
analysis.
everyone panics, So the internist panics, the patient panics. Most internists will send that person to a urologist. I will usually repeat it once, first step, which I think is a missing step from a lot of internists, because most of the time it's nothing.
Just trauma.
They were running.
Yeah.
They literally, anything could cause a couple drops of blood.
Yeah.
It's a problem if it's persistent. That we should use the word. It's persistent microscopic hematuria. That's the problem. So then we send them to you. What are the causes? Why is it usually not a problem? How often is it a problem?
Yeah. So I think most urologists hate microscopic hematuria, right? It's very annoying because it's hard to identify something.
Right.
Well, a lot of times it's hard. But the concern with microscopic hematuria is if you have any cancer along the urinary tract, whether it's in the kidneys, the ureter, the bladder, potentially the prostate, even the urethra, right? So yeah, like you said, doing two UAs is great. If it comes back positive, and there's various numbers, right? 1 plus, 2 plus, 3 plus. So if it's 3 plus, it's just a quantifier, right, for the UA. At that point, you have to investigate. It's imaging, a cystoscopy, just to make sure everything's okay. And usually you're able to identify something to it, but sometimes you're not, and that's when it becomes extremely
But it can be
annoying.
something benign. So it can be a stone, it could be a cyst, it could be all these other things.
They're having like a
urine infection.
UTI.
Yeah.
Or even after sexual performance, it could be anything as simple and benign as that sometimes.
And how often for women who are still menstruating, do they just get a little bit of blood in there, and that is really not a big deal too?
You mean in there?
Yeah.
So we always try to identify, right? You always try to identify in terms of where's it coming from?
Right.
Is it coming from the vagina or is it
Right.
coming from the urethra?
Right.
If we have any question, we straight catheterize them and just take a sample,
A clean sample.
clean sample.
Yeah,
exactly.
got it.
Kidney stones look really painful. They're one of the few things where you see a patient and they're writhing around and they can't get comfortable. You just, there's such a look of so when someone comes with pain, even if someone has like, let's say right lower quadrant pain, it could be the appendix, could be a kidney stone, there's just such a look of someone with I say like a kidney stone, you can't be still. You're like turning left to right.
They say it's worse than delivering a kid, right? Women
That
say
makes
it's-
sense.
Yeah.
Wow, that sounds painful.
It
It's
looks
severe.
terrible.
Yeah, it's so much pain. It really is a lot.
It
of
looks
pain.
terrible.
Do you ever have to actually open up and actually do real surgery on someone for a kidney stone?
Not anymore. Those
Not
days
anymore.
are done.
Those days are gone. Okay.
Oh yeah. The most invasive you get is if it's a huge stone in the kidney, you would have to develop a track through the lower, through the flank area, a percutaneous.
The lower back, and you actually put something in there?
Yeah, you basically you find access from the skin. You basically develop a track from the skin into the kidney,
Whoa.
and you blast the stone from there.
Oh my gosh.
Yeah, but
wow.
the days of opening up, like opening skin, and
Take out the stone, those are done.
those days are done.
Wow, it's so
Very
good.
rarely is that.
I
done.
love
Very
the
rarely.
advances. And then
Oh, yeah.
lastly, let's touch on cancers, just so we can do a full round of urology.
Yeah.
Why do you guys use the robot so much? Are you guys obsessed with robots?
Yeah, so the robot is great, right? The Da Vinci robot. So what it does is it gives, now it's used for everything, right? General surgeons, I don't know if you used it in residency.
We did, just to play around with.
It's fun, right?
Yeah, it's super fun.
It's fun.
Yeah.
It's fun. So for us, in the pelvis, it's great because it's for the prostate. We initially started using it for the prostate, and the reason why we use it is because the nerves for erections ride along the prostate, right, posterior lateral on both sides, and in order to peel those nerves off without taking them, without sacrificing while removing the prostate, you need high magnification and you need dexterity. And that's what the robot provides. It gives you the opportunity to just peel off those nerves safely. And we've seen, in terms of continence rates after prostatectomy, in terms of erectile function rates, like potency rates, guys have done much, much better with the robot than they did previously with open surgery, laparoscopic surgery. Yeah.
So to say that again, just a little slower. So meaning the old prostatectomy, when they used to take it out, would cause both incontinence, which means you lose your urine by accident.
Yeah.
And then erectile dysfunction also. And sometimes also, from what I understand, is when you try to ejaculate, it's revert, like it doesn't come outside.
Well, when the prostate's out, you're no longer ejaculating. You're able to orgasm, and that pleasure is always going to be there. But you're never going to
There's
really
no semen.
Right. Nothing comes out anymore, so it's a lot cleaner.
And how do you guys decide between radiation, surgery? So if someone does have prostate cancer, which for men is the most common type of cancer, a lot of times, these are slow growing cancers. So if someone's older, a lot of times, they're unlikely to die from the cancer. So we actually just watch it and sort of leave it alone. But if someone's on the younger side, when they get it and it's growing and looks more aggressive, how do you decide radiation versus surgery?
Yeah. I mean, you were a urologist in your past life. You know a lot about this.
You know what? I try to know a lot about everything.
Yeah.
Whenever I think one of the nice things about the way my practice works, that I have free time built into my schedule. So when I have a patient who sees any specialist, I discuss the case with them.
Yeah.
And so I pick up a lot from every specialty because I'm literally like going through that consult with their thought process each time. So I'm learning a lot each time.
Yeah. So I mean, I mean, it's really what it comes down to. The two treatment options: radiation. I mean, active surveillance. You just watch them. You monitor. There's radiation therapy, and there's different forms of it. And then surgical resection, with typically the Da Vinci robot. But deciding between the two, prostatectomy versus radiation, a lot of it has to do with shared decision making with the patients, what they want. But if it's a sicker patient who probably can't tolerate surgery for the anesthesia risks and whatnot, radiation may be a better option for them. But if it's a young guy who has good erectile function going into the case, he's going to probably has 20, 30 years longer to live. Yeah, you'd recommend surgical management for it.
And biopsy would obviously be the first step before you would do any of this. Because sometimes even if you feel something on digital exam that feels weird, it may not be anything besides benign.
Exactly right.
So I've even found that a lot of older urologists don't even realize how great the MRIs are. And so that's something that I've found to be extremely helpful and even guiding when you even need a biopsy. And then when you do the biopsy, they're scored to see how potentially abnormal this. So we always use the word cancer, and the word cancer can really mean like a wide, from something that's really pretty benign looking to something that looks very scary.
Right.
And we find that out by doing a biopsy. We look under the microscope, and prostate cancers get a Gleason score. It's a score that says how likely this thing is to be aggressive. And that often guides what we're going to do depending on, again, these same things, age, comorbidities, because we're always weighing what is the risk. So the word cancer is scary. And anytime someone hears cancer, they're like, get this thing out of me.
Yeah.
But sometimes the get this thing out of me is actually worse than the cancer, depending on your age and comorbidity. So we have to think about that part when we're deciding what to do.
Right. For slow growing cancers.
But I will say that a prostate biopsy also is one of the things that is every patient is so scared of, understandably, because they are literally explain how you do this and explain what it's like.
So we numb them up. I'll say this.
So where do you put the needle? What position are they in?
Yeah, they're going through the rectum.
Through the rectum, right? You're putting an ultrasound probe, probably, the thickness of a big thumb, right? Through the rectum. You're getting a good visualization of the prostate, just given where it is relative to the rectum. And what you're doing is you're putting in a needle through the ultrasound probe, and you're taking anywhere from 12 to 14 to 16 biopsies, specimens. And
almost like different parts of the prostate.
Yeah. So we break up the prostate into, depending on what school of thought you belong to, 6 parts, 12 parts. And then you always, if now with the fusion MRI, the MRI has really changed things.
You localize it's kind of like an archaeology dig where it's in like 2, 3, and that's like the one you're aiming for, right? Or whatever.
Well, that's true for like the whole prostate.
Right.
But then when you're nailing, you're just trying to get that nodule or that suspicious lesion on MRI. You're able to, with the new technology that we have now, you're actually able to find, you're able to fuse the MRI with the ultrasound in real
Wow.
time.
Yeah.
So you're actually able to see exactly where it is and target it. And that's changed everything.
Yeah,
It's really changed a lot of stuff.
And it's live. You're monitoring where your needle's
Yeah.
going live, which is amazing. And it
Absolutely.
matches up with the imaging that you had beforehand.
Exactly.
Yeah, it's very similar technology we use in the brain and the skull base and the sinuses. It's called our brain lab, where you have an active CT or MRI that we were actually operating on live.
So you could see the lesion.
You can
the
see
tumor.
exactly
'Cause
where
you
it
guys-
is and where it goes.
You guys have the patient wear that whole reconstruction thing during the CT, right?
During the CT, yep.
Yeah.
And it's because we're going to use that during the surgery.
Right.
And so and that's very common. Anyone who gets sinus surgery, just like a prostate biopsy, it's the exact same thing. You do a very specialized scan so that we're going to use that during surgery.
Amazing.
Yeah.
You guys have been doing that for a while, though, right?
20 years.
Yeah. See, this is very
20
new
years.
for us.
Yeah.
Yeah.
You guys,
Things work the ways down the body, starts with the head and gets down to the prostate.
So whoever said the two of you weren't useful, they've got to take it back now.
Yeah, I think so. I think subspecialty surgeons are very useful.
Very
Absolutely.
useful.
In their niches.
I think,
Hell yeah.
it's funny because doctors always, the different specialties compete with each other or argue and joke around, especially, during residency. Because
Yes.
during residency, you spend, 100 hours a week with
Yeah.
your colleagues.
Well, you're
and
different
the
frats.
thing that
It's
you're
different
basically
frats.
different frats.
Yeah.
And so when you get consulted by the other one, you're like, oh my God, I can't believe
Yeah,
you're
yeah,
consulting me about this again.
Delta Chi, hate
But
those
then you
guys.
but then you realize how much you need them.
Yeah, oh,
So-
absolutely. They save your butt sometimes.
Yeah.
That's
And
huge.
then
or
when
in some
you're-
cases, they stick a needle through it.
And then when you're in practice, you really appreciate it, right?
Yeah,
then
of
you really
course.
appreciate it. Oh my gosh.
Thank you so much for the consult.
Yes, yes. Oh,
Exactly.
Thank you for saving.
Thanks
yeah,
for the
yeah.
consult.
Absolutely. Well, what a great conversation on men's health, erectile
Yeah.
dysfunction,
Appreciate you coming.
cosmetic penises. I mean, what a great.
So if
great-
a patient wants to have a men's health consult or listening to this, how do they find you? Where do they find you? What's the best way to make an appointment to see you?
Yeah. So, my practice is at Cedar Sinai, where the medical tower is right by Cedar Sinai. You could Google my name, Justin Houman, Houman. Available for same day, next day consults. So you could see me very, very quickly. But yeah,
Are you doing virtual consults right now as
yeah,
well?
we do virtual consultations as
Okay,
well.
That's
awesome.
fantastic.
Thanks
Yeah.
for coming. We
Great.
appreciate it.
Yeah. Thanks
Really
for having
great
me, guys.
episode.
Thanks
Thank
for
you.
the locker room talk.
Yeah, great. Medical locker room talk.
Yeah, we all learned something.
Thank you so much.
All right, guys. Appreciate it.
All right. Well, thanks for listening. Episode 16, Jeff's.
I learned a lot.
Yeah, I learned a lot.
How much of that episode were you erect?
Zero part of it. But I do
No,
not
that was
have-
a great episode.
Oh, it was so good. I learned a ton.
I learned a ton.
Yeah, and I feel like it was so good to finally talk a little bit about men's sexual health because we never explore that as guys. We never do,
Yeah.
and it's important for women listening right now to understand how important men's sexual health is.
Yeah, so if your guy's having trouble here and there,
Yeah.
First of all, it's normal. It
Mhm.
happens to
The best of us.
a lot of people.
Yeah.
And sort of maybe convince them they should see the doctor.
Yeah.
You can even, I think a good advice is, say maybe it's time for a checkup
Yeah, check up.
and you don't even need to say, get that checked out. And,
Right, because it's an awkward conversation. No guy wants to be told that they're not performing well.
Yeah.
But that being said, we want to be the best at every part of our lives.
And again, I think sometimes it's especially for middle-aged men, it can be a sign of some other medical issue.
Right, very important. So annual checkups, regardless, and then during that checkup, let it come out if it's an issue.
All right. Well,
Thanks for listening, guys. Episode 16 was awesome.
make sure you share this one.
Yep, share,
Like it.
subscribe. Definitely send this to your male friends, to your significant others. This is a great one for every single guy in the world needs to listen to this one.
Thanks for listening.